Hello, my name is Angela Davis, and I will be presenting today's clinical case study. This case involves a 32-year-old Caucasian female. She has a past medical history of tension headaches, depression, and anxiety. Her surgical history includes a cesarean section at the age of 30. She has no allergies. Her medications include Wellbutrin 1 time daily, Yasmin 1 time daily, and acetaminophen every 6 hours is needed for headaches. Her last menstrual period was 1 week ago. She has been married for 6 years, has a 2-year-old daughter, and lives in a 2-bedroom apartment. She works part-time at Target 3 nights a week. She has never smoked, drinks alcohol on rare occasion, and has never used illicit drugs. Her diet mostly consists of pasta, minimal whole foods, and anything she can quickly make in the microwave. She takes a daily walk with her daughter to the park when the weather is nice. Otherwise, she does not do any routine exercise. She was an avid runner, but is unable to tolerate exercise like she used to. Her hobbies include reading and doing puzzles. She is sexually active and taking the birth control pill, as noted. She has no recent travel, domestic or international. And her pertinent family history includes her maternal grandmother having rheumatoid arthritis. This patient presented to primary care with multiple symptoms, including fatigue, muscle aches, cold intolerance, hair loss, weight gain, and constipation. She first noticed the extreme fatigue a few months after her daughter was born and thought it was related to being a new mom. She anticipated it would resolve once her daughter began sleeping through the night. However, new symptoms developed and the fatigue persisted. She has been experiencing persistent muscle aches, and they have been interfering with her daily activities. Vital signs were obtained and a comprehensive physical examination was performed. The abnormal findings of the physical exam include an 11-pound weight gain in the last year, hoarse voice, skin is cool to the touch, her nails are dry and brittle, her hair is thin, dry, and coarse, her deep tendon reflexes are diminished with a positive Woltman sign, her thyroid is enlarged and firm, she was bradycardic, and she is showing a depressed mood and affect. The patient's fasting blood work results showed that her CBC and CMP were just slightly under normal values. Her hemoglobin A1C was normal. The lipid panel showed elevated LDL and total cholesterol, and her thyroid function studies revealed an elevated TSH and low T3 and T4. A urine HCG was done and negative. After these initial labs resulted, she was sent for additional testing, which included thyroid peroxidase antibodies, thyroglobulin antibodies, and an ultrasound of her head and neck. Based on all the information provided, what diagnosis is suspected? Results from the additional blood test revealed an elevated thyroid peroxidase antibody level of 131 international units per milliliter. The ultrasound of head and neck revealed a thyroid that is enlarged, hypoechoic, and hypervascular with a micronodule pattern. With the patient's symptoms, physical exam findings, blood studies, and ultrasound in mind, that leads to the diagnosis of Hashimoto's thyroiditis. Hashimoto's thyroiditis is also known as chronic lymphocytic thyroiditis or chronic autoimmune thyroiditis. It is an autoimmune disorder which involves the formation of anti-thyroid antibodies, which attack thyroid cells as if they were bacteria, a virus, or some other foreign body. It typically presents with an elevated TSH, decreased T4, and the presence of thyroid peroxidase antibodies and or thyroglobulin antibodies. It is important to note that 10% of patients may be antibody negative and still experiencing symptoms. This can make the diagnosis of Hashimoto's difficult. The antibodies cause inflammation and progressive fibrosis, which results in an enlarged thyroid gland and hypothyroidism. Lymphocytic infiltration and follicular destruction are the histological hallmark signs of Hashimoto's. The presence of chemokines and cytokines play an important role as they will eventually cause atrophy of the thyroid. This slide illustrates a normal thyroid compared to a thyroid you would see in Hashimoto's. The signs and symptoms of Hashimoto's can mimic other disease processes or even be dismissed as the normal changes that come with aging. The patient in this case study was affected by all of these except for a pale or puffy face and irregular menstrual cycle. Hashimoto's is the most common cause of hypothyroidism in developed countries. Although the etiology is unknown, it is thought to be related to genetics or environmental triggers such as infection, smoking, stress, or both. Women are 7 to 10 times more likely to develop Hashimoto's, and while it can occur at any age, it is most common in middle age. Other risk factors include having another autoimmune disease, such as rheumatoid arthritis, lupus, or celiac, a family history of Hashimoto's or other immune disorder, pregnancy, excessive iodine intake, or radiation exposure. There is currently no genetic testing available for this diagnosis. Complications can lead to heart problems such as an enlarged heart or dysrhythmias, mental health issues, reproductive dysfunction, poor pregnancy outcomes, or myxedemia, which is a rare and life-threatening condition due to advanced hypothyroidism. If left untreated, it could also result in a papillary thyroid cancer. Some of the comorbidities found in patients with Hashimoto's include anemia, decreased kidney function, elevated creatinine kinase, which contributes to muscle pain and swelling, increased prolactin, elevated total cholesterol, LDL, and triglycerides, which lead to cardiovascular issues, other autoimmune diseases such as diabetes, Sjogren's, celiac, rheumatoid arthritis, or lupus may already be present. The initiation of thyroid hormone therapy, such as levothyroxine, is the first step in the treatment plan. Dosing starts at 1.6 micrograms per kilogram per day orally. There is no one-size-fits-all dose for thyroid hormone therapy, so monitoring is essential. Thyroid levels are checked after 6 weeks of therapy, and if changes are made to dosing, they will be reevaluated in another 6 weeks. This process will continue until the level of thyroid hormones are optimal and symptoms have been managed. Some patients may feel improvement in symptoms after only a week of therapy, where other symptoms, such as hair and nail issues, can take 3 to 6 months to resolve. Integrative and functional medicine practitioners assess and treat free T3 levels by adding liothyronine, also known as Cytomel, to a patient's treatment plan. However, this approach is not typically done in Western medicine. Patients should be provided with thorough education on Hashimoto's. They need to be made aware that it is a lifelong condition and they should never abruptly stop their thyroid medication. It should always be taken on an empty stomach at least 1 hour before a meal to promote absorption. Many patients take their thyroid medication as soon as they wake up to meet this parameter. Additionally, patients should be made aware to avoid foods high in fiber, iron tablets, calcium or aluminum containing medication, as this can also interfere with absorption. It is important to make them aware of the need for routine follow-ups, discuss symptoms that should be immediately reported to the provider, and provide written education for review at home. Although there are currently no official dietary interventions that are recommended for the treatment of Hashimoto's, it is suggested that following an anti-inflammatory diet, such as paleo, which eliminates dairy and grains and focuses on healing the gut, it will have a positive impact on controlling Hashimoto's. There are many vitamins and minerals that play a role in thyroid function. Selenium, for instance, participates in the synthesis of thyroid hormones. It is important to educate on the potential need for supplementation. Hashimoto's decreases glucose absorption, which can eventually lead to insulin resistance. Therefore, education on controlling blood sugar is vital. Although stress has not been recognized as a risk factor, it is well established that it affects endocrine and immune mechanisms. Instruction on stress management techniques, such as acupuncture, breathing exercises, or massage, can be helpful. Exercise can also help with stress as well, and additionally helps with weight control. This may be difficult for newly diagnosed patients, but should be promoted. Providing a patient with a list of support groups or referral to a counselor may be warranted. Lastly, it is important to provide reassurance to the patient that Hashimoto's is manageable and treatment plans can be adjusted when needed to help control symptoms. That will conclude today's clinical case study on Hashimoto's thyroiditis. I hope you found it to be informative and useful for your clinical practice. Thank you for your time today.